Good morning, everyone. Thank you for joining us this morning. My name is Camilo González Velázquez. I am an associate professor in endocrinology at the Universidad Autónoma de Nuevo León in Monterrey, Mexico, and co-host of this TIRO by MD's webinar series. I'm incredibly happy to announce that this week we're celebrating our 2-year anniversary since we started this webinar series. And after a couple of COVID variants, we're still here with the same enthusiasm and, most importantly, safe, as we hope that you all are. Today, I'm honored to introduce 3 wonderful speakers. Our presenters this morning will be Dr. Grace Banik, Dr. Maisie Shindo from the Pediatric Otolaryngology Department in Children's Hospitals in Philadelphia. Dr. Grace Banik is currently an otolaryngology fellow. She had an undergraduate degree in biochemical sciences from Harvard University. She graduated medical school with distinction in research from Case Western Reserve University School of Medicine, and did her residency years in Oregon Health and Science University. During her training years, she has developed an interesting focus on tumor microenvironment and clinical outcomes in pediatric thyroid cancer. Additionally, we are delighted to have Dr. Gary Francis. Dr. Francis received his PhD degree from the University of Florida, followed by his residency in pediatrics. He has completed his fellowship in genetics, endocrinology, and metabolism in the University of Oklahoma, and has a clinical associate and was a clinical associate at the National Institute of Clinical Health and Development. He currently serves as a professor in the Division of Pediatric Endocrinology and Metabolism at the University of, I'm so sorry. I'm so sorry. My connection is a little bit unstable. Dr. Banik would also be presenting with us this morning. To the side with Dr. Shindo. Dr. Shindo needs no introduction. As you know, she currently serves as the director of Thyroid and Parathyroid program at OHSU in Oregon Science University. And with no further introduction, I'll give you the mic to you, Grace.
Thanks so much, Dr. Gonzalez Velasquez. Good morning, everyone. I'm Grace Banik. I'm, as you mentioned, a pediatric otolaryngology fellow at the Children's Hospital of Philadelphia. Let me go ahead and share my slides here. All right, so on behalf of myself and all of my co-authors, thanks for the opportunity to present our work in this forum. It's a true honor also to have Dr. Francis as the discussant today. I'm very much looking forward to hearing and learning from Dr. Francis's talk to follow. I have no financial disclosures. So I'd like to start my talk today by giving a bit of background on pediatric thyroid cancer. Pediatric thyroid cancer is quite rare, comprising only 2% of all thyroid cancer. But some recent studies have observed that its incidence is increasing by an annual percent change of approximately 4 to 5%. Similar to adult differentiated thyroid cancer, papillary thyroid carcinoma comprises the vast majority of pediatric differentiated thyroid carcinoma. However, pediatric PTC is very much a unique entity with distinct clinical pathologic features compared to adults. So children with PTC tend to present with more advanced disease, including higher rates of extracapsular extension at rates of up to 50% compared to 30% in adults, regional lymph node involvement in up to 80% compared to 50%, as well as distant metastases in up to 30% compared to 5%. In addition, as Lee et al. Recently described in the Journal of Clinical Investigation, the molecular characteristics of pediatric PTC are unique as well, with greater frequency of oncogenic fusions such as RET and NTRK fusions, and fewer traditional point mutations such as your BRAF V600E. So the highly aggressive diffuse sclerosing pathologic variant is also more common in children. And finally, there are significantly higher rates of recurrent and persistent disease in children, somewhere in the 30% range in the literature. Now, another unique feature of pediatric PTC is that multifocal disease in one or both lobes tends to be more common in children than in adults. Moreover, as you can see in these survival curves by Lee et al., multifocal tumors seem to correlate with slightly worse recurrence-free survival in children compared to adults. This bottom curve represents the recurrence-free survival for patients who are aged less than 20, compared to these other age groups, older age groups above. So multifocality really represents a potentially important factor to consider in management decisions in pediatric PTC. Now, the current pediatric thyroid guidelines written by our discussant, Dr. Francis, do address this issue of multifocality. To provide a bit of context, it's important to note that prior to 2015, the management of pediatric thyroid cancer essentially just followed the adult guidelines. The adult ATA guidelines state that lobectomy is actually an acceptable alternative in low-risk PTC. However, in 2015, the ATA recognized that pediatric thyroid cancer is a bit of a unique entity and issued pediatric-specific guidelines. These guidelines recommend largely against lobectomy, citing the increased frequency of multifocal disease in children, as well as studies that demonstrated improved disease-free survival with total thyroidectomy. However, more recently, there has been kind of a renewed interest in the idea of a more conservative approach to pediatric PTC. This is reflected in the AAC H&S pediatric thyroid guidelines that were issued in 2020, which suggests that lobectomy can actually be considered in children with small solitary PTC. And then a notable recent contribution to this discussion is a study by Sudoku et al. That found that in unifocal T1A and 0 PTC in children, there was about a 95% rate in their cohort of just unilateral disease. So this renewed interest in more conservative surgery and pediatric PTC is largely driven by the increased risks of complications from total thyroidectomy in children. We know that they have higher rates of hypoparathyroidism as well as recurrent laryngeal nerve injury. And additionally, there's this question of whether the improved disease-free survival from total thyroidectomy in children really matters when the overall survival in pediatric PTC is still nearly 100% for all comers. So that brings us to the crux of our study today, this need to determine which, if any, children may be appropriate candidates for more conservative surgery. Specifically, our objective was to determine the prevalence as well as risk factors for multifocal disease in pediatric PTC, again, with the goal of informing this debate around more conservative surgery. This was a large multi-center retrospective cohort study and really among the first of its kind in pediatric thyroid cancer. We were fortunate to have an amazing collaboration between 5 institutions, CHOP, Lurie, OHSU, Texas Children's, and MD Anderson, which enabled us to achieve a study population of 212 children, which is really one of the largest in the literature for pediatric thyroid. Our study included patients up to the age of 18 who underwent surgery for PTC and focused on demographic and clinical characteristics that would be known preoperatively. We intentionally excluded variables that would have been found after the fact on pathology in order to really build a predictive model for surgical decision-making. So then we performed a multiple logistic regression analysis to determine which variables were associated with multifocal disease, including both unilateral multifocal disease and bilateral disease. We then performed something called a least absolute shrinkage and selection operator, kind of a mouthful, but LASSO analysis for short. LASSO is essentially an extended form of regression analysis that incorporates machine learning into regression analysis to minimize error and increase accuracy. It takes a set of variables and over multiple iterations reduces them to select for more strongly associated variables and then shrink or select against more weakly associated variables. And as a result, the final LASSO model only includes variables that are truly predictive, and those with larger coefficients are, theoretically have stronger associations with the outcome variable. And as you will see shortly, though LASSO is not necessarily a currently widely used statistical method in the medical literature, it does have quite powerful potential applications in developing these predictive clinical models. As I mentioned, our final cohort consisted of 212 children who underwent surgical management of PTC. Of note, likely due to the larger size of our study, we were able to capture even some rare subgroups of pediatric PTC patients, such as those less than 10, age less than 10, and then male patients. 12% of our patients had a family history of thyroid cancer, while 32% had a diagnosis of autoimmune thyroiditis. And then 5% had prior radiation exposure, while 4% had a thyroid cancer predisposing syndrome, such as FAP or Cowden's. We had a fairly even distribution of patients across tumor sizes, as you can see. The majority of patients had the classic pathologic variant, though we did have 15% of patients with the follicular variant, and then 8% with diffuse sclerosing. We did not capture many patients actually with T4 disease, unfortunately, but did have an even distribution across the other T and N stages, as well as 12% of patients with metastatic disease. So an important finding was that only 28% of multifocal disease was predicted on preoperative imaging, and that there was a not insignificant false positive rate of 5%. Ultimately, about 46% of our cohort had multifocal disease, and nearly 3/4 of that was actually bilateral. Interestingly, preoperative imaging was far more accurate in predicting bilateral multifocal disease at a rate of 66% compared to 36% for unilateral multifocal disease. On multiple logistic regression analysis, the only significant predictors that we found for multifocal disease in general were bilateral N1B and M1 stage. In contrast, lasso analysis actually picked up several additional potential predictors, including age less than 10 and T3 stage. In this table, variables that are labeled as NI, it just indicate that they were not included in the final predictive lasso model due to weak associations with multifocal disease. I would also like to point out that it's interesting that while T3 was a predictor of multifocal disease, tumor size of 2 to 4 centimeters was not. And I'll talk a little bit more about this discordance further in a later slide. Now, if we look at predictors of specifically bilateral multifocal disease, only bilateral N1B stage was a significant predictor on multiple logistic regression analysis. But again, lasso analysis picked up several additional potential predictors, including age less than 10, T3 stage, and then of note, I'm not showing any data for predictors of unilateral multifocal disease because there were no significant predictors found on multiple logistic regression or lasso analysis. And that's likely due to the small subgroup size for for unilateral multifocal disease that I mentioned earlier. So to review some of the key takeaways from our study, we found that the prevalence of multifocal disease was about 46% in our cohort and 34% for bilateral multifocal disease. This is higher than prevalence rates of multifocal disease in adults and is consistent with numbers from some of the larger pediatric studies that have looked at this, such as Spinelli, for example, who reported a rate of 40.4% for multifocal disease, and then Chirella et al., who recently reported a rate of 41% for bilateral multifocal disease. Our multiple logistic regression analysis and lasso analysis revealed several potential predictors of multifocal disease, as I mentioned. These include younger age, advanced T stage, bilateral lateral neck involvement, interestingly not unilateral lateral neck involvement, as well as presence of distant metastases. With regards to younger age, the previous data is conflicting a bit, but Chen et al. Recently demonstrated in a nice study that there was an association between younger age and recurrence in children with multifocal disease. With regards to advanced T stage, earlier I mentioned that we had identified T stage as a potential predictor of multifocal disease, but not tumor size, which you might be thinking is somewhat discordant. But if we think about what defines T3 stage, tumor size of 2 to 4 centimeters is only one component, while extrathyroidal extension is the other. So our finding actually kind of points to this possibility that perhaps extrathyroidal extension may be the more important driver of the two of more aggressive disease, such as multifocal disease. And lastly, in our study, lateral neck disease was only predictive of multifocal disease if present on both sides of the neck. And this finding suggests that the inclusion of laterality in nodal staging may be worth considering in pediatric thyroid cancer moving forward. Now, another interesting finding of our study was actually the overall poor predictability of multifocal disease on preoperative imaging, with only 36% of unilateral multifocal disease and 66% of bilateral predicted. Previous studies have suggested kind of far greater predictive accuracy of preoperative imaging. Kloof-Yout is one group that reported only 6.1% of multifocal disease getting missed on preoperative imaging. And our low rate may reflect variability in perhaps technique, quality of the preoperative workup. It was a multi-center study, and so there may be an introduction of additional variability from that compared to a single center study. But I think ultimately it just really underscores the importance of high quality ultrasonographic evaluation in the preoperative workup for pediatric PTC. Now, our study did have several limitations, including its retrospective nature and then the limited number of certain patient subgroups. Additionally, we did not assess pathologic features or long-term outcomes, as our focus really was on developing a preoperative predictive model for multifocal disease. However, these are future directions that will certainly be important to explore. So what is the ultimate clinical applicability of our study findings? Ultimately, multifocality is just one consideration in the decision between lobectomy and total thyroidectomy in children with PTC. Our hope is that the study helps to clarify and perhaps strengthen the role of multifocality in this overall schema. Further study of the association between multifocality and outcomes in children will also help to clarify this importance of multifocal disease. And lastly, large multi-center studies are needed to guide management of pediatric thyroid cancer. And this is particularly true because of kind of historic limitations in the research of pediatric thyroid cancer, due to small patient numbers and the rarity of this disease overall, as well as kind of a fragmented approach that has been taken and largely single center, small cohort approach that's been taken to researching pediatric thyroid cancer in the past. And with that, it's been an honor and a pleasure to participate in this multi-center collaboration and to be able to present our work today. Thank you very much.
Thank you, Dr. Banik. I am very interested to see if Dr. Shindo has any comments on Dr. Banik's presentation, and we will go ahead, please.
Oh, go ahead. I'm sorry, I didn't mean to cut you off.
No, by no means, please go ahead.
Yeah, no, it's so, I think that the thing that's one of the reasons why we started this project was to answer that question. Can we use evidence-based data to move to more conservative surgery in children for low-risk tumors that we, are now, it's pretty standard in adults. So if you look at the N1 disease and T3, it really doesn't matter, right? So once you have N1A disease or N1B disease or T3, which was, the two variables that were associated, we would do a total anyway. So it's somewhat irrelevant from that decision-making standpoint. But I certainly think that age less than 10 is something we need to look further into because both the regression analysis and the lasso is suggesting that maybe this is, one of the variables And I certainly think additional studies focusing on that may be worthwhile. But from a clinical perspective, I think that the other two variables may not really matter from a surgeon's standpoint and making a decision. Now, from a standpoint of the endocrinologist and the medical oncologist, I see Dr. Sherman's here. And so, in terms of surveillance, if they have contralateral disease, I mean, even though we focus using ultrasound and other imaging modalities, if they have contralateral disease, we want to, look at the other side very closely in the surveillance as well.
Correct. Thank you so much. With that, we will hand the mic to Dr. Gary Francis for his discussion.
Thank you. So first, I'd like to thank Dr. Banik for such an informative presentation and congratulate all the authors on this manuscript for a well-conceived and well-written study that addresses an important question as we move forward to update our pediatric thyroid cancer guidelines. Next slide. I do have financial disclosures. There are a number of pharmaceutical companies in which my retirement portfolio holds a professionally managed interest. I do not individually manage those. Next slide. So when we talk about total thyroidectomy in children, we need to consider the potential risks and benefits. As we've heard, the risks of recurrent laryngeal nerve injury or persistent disease are the two variables that we need to weigh. Studies in the past, particularly by Ian Hay, showed that recurrent or persistent disease can be decreased from about 35% to 6% in his study with total thyroidectomy compared to less than total thyroidectomy, but not all studies support that finding. Furthermore, total thyroidectomy does facilitate the use of radioactive iodine. Thyroglobulin utility for follow-up, we now have some guidelines, at least from the adult world, for thyroglobulin measures in patients post-lobectomy to be able to utilize thyroglobulin determinations for assessing recurrent disease. So that may not be as useful an outcome from total thyroidectomy as it has been in the past. The risks, hypoparathyroidism and recurrent laryngeal nerve injury, you've heard, are quite high in pediatrics, but if we look at high volume centers, such as contemporary data from Children's Hospital Philadelphia, where more than 810 total thyroidectomies have been performed, the risks for hypoparathyroidism and recurrent laryngeal nerve injury are quite low, less than 1%. Again, underscoring the utility and the necessity to have these procedures done in high volume centers. Next slide. So in theory, total thyroidectomy would most benefit those with bilateral disease. For those without bilateral disease, unilateral disease would be amenable to lobectomy and ipsilateral node dissection. So the questions well addressed in this paper are, can we predict bilateral disease either preoperatively or postoperatively? Next slide. And they had an interesting cohort with which to address that question, and one that I think is very important. As you heard, about 44% of their patients had N1B disease, and about 40% had either T3 or T4 tumors. In order to address whether or not bilateral disease can be predicted, you would need patients with a high risk of having bilateral disease. So you'd not want to study a large number of patients with small indolent tumors and either N0 or N1A disease. So this cohort, I think, is very appropriate for their study. Next slide. As you heard, their preoperative imaging identified 28% of patients with any multifocal disease, but about 66% of those with bilateral disease. Now, when I read the paper, I did not identify the imaging criteria that were used for prediction, but when I contacted the authors back in February, they identified that clinical judgment was used to predict preoperative evidence of bilateral disease based on ultrasonographic features of both lobes with similarly suspicious sonographic characteristics: solid, hypoechoic, taller than wide, invasive margins, extrathyroidal extension, and punctate echogenic foci. So those criteria are out there and I think are very appropriate for suspicion of significant bilateral disease. Neither previous radiation exposure nor predisposing cancer syndromes in their study predicted bilateral disease, but the numbers were small. There were only 11 patients with radiation exposure and 8 with predisposing cancer syndromes. And I think many experts would still recommend total thyroidectomy for those cases. Predisposing cancer syndromes are germline mutations, which affect all cells in the thyroid. So if you leave thyroid behind, those cells are still at risk. And radiation exposure impacts all cells in the thyroid and again, would confer increased risk for any remaining thyroid tissue. Interestingly, they did include some cases with multiple endocrine neoplasia in their study. And you've heard the findings from their lasso analysis that age less than or equal to 10, T3 and above tumors, bilateral N1B disease and distant metastasis predicted bilateral disease. And on multiple regression analysis, only bilateral N1B disease remained as a predictive factor. Next slide. So how does that compare to other data? Next slide. Study by Cirella, published in 2021, looked at 115 pediatric thyroid cancer patients, again, small numbers with radiation exposure and cancer syndromes. 74 of their patients had bilateral disease, and that was more common with FNA findings of Bethesda category 5 and 6, sonographic features of irregular borders, calcifications, solid architecture, and abnormal lymph nodes. Of note, however, none of their follicular thyroid cancers was bilateral. And I think most importantly, 84% of those with unilateral disease who were clinically node negative and had no multifocal disease in the primary lobe. So the vast majority of patients with clinically node negative and no multifocal disease in the primary lobe only had unilateral disease. Next slide. And those findings are similar to the study presented by Dr. Banik this morning. 69% of their patients who were node negative had no multifocal disease, and 81% who were node negative had no bilateral disease. So again, the absence of clinical nodes is an important finding. Only 7 node negative patients had multifocal disease, but it was not bilateral. Next slide. So what about postoperative characteristics? Well, in the study by Cirella, papillary histology, multifocality in the primary lobe, extrathyroidal extension, lymphovascular invasion, and pathologic lymph node metastasis were important predictors. But on multiple regression analysis, only multifocal disease in the primary lobe predicted bilateral disease. So just as in the Banik study, there seems to be something about multifocality that appears to be intrinsic to the cell type or to the cell molecular biology that allows multifocality and invasion. Next slide. There's another study by Chen published in 2019, 90 pediatric cases. Again, 84% were N1B disease, so it was a cohort with widespread disease. 75 patients, or 83%, had bilateral disease, and their predictors were extrathyroidal extension and lymphovascular invasion. Again, supporting the discussion from Dr. Banik this morning that it could be extrathyroidal extension in the T3 tumors that's the important predictor. Next slide. Now, 11 of their patients were treated with lobectomy, 79 with total thyroidectomy, and about half received radioactive iodine. And although extrathyroidal extension and lymphovascular invasion predicted recurrence, the disease-free survival was similar whether patients underwent lobectomy or total thyroidectomy and whether or not they received radioactive iodine. Now you should temper that a little bit with the fact that only 11 of their patients were treated with lobectomy, but it is still an interesting observation. Next slide. So I think we could ask, can some of these preoperative staging factors predict bilateral disease? What if you did total thyroidectomy on patients who were less than 10 who had radiation exposure or predisposing cancer syndromes, who had preoperative imaging showing bilateral disease, or who had distant metastasis, which can be identified preoperatively on chest CT. And that would add up to about 116 of the patients in the Banik study, or about half of all their pediatric cases. And it might include all 73 with bilateral disease. That analysis has not been done. So I think that's one consideration for how you might approach this question. Next slide. Another consideration would be to look at lymph node disease postoperatively. So bilateral N1B disease was found in 58 of their patients, ipsilateral N1B disease in 36, which will be a total of 94 patients, and again, might include all 73 with bilateral disease. Next slide. So I think from all of these studies, we can conclude that bilateral disease is common in pediatric series, ranging from 34 to 83%. Most is predicted by young age, less than 10, prior radiation exposure, predisposing cancer syndromes, preoperative imaging showing lesions in both lobes with similarly suspicious sonographic features, distant metastasis, N1B disease, extrathyroidal extension, and lymph node involvement. Next slide. Conversely, I think we could consider a recommendation that patients who are clinically node negative with no multifocal disease in the primary lobe would be appropriate for lobectomy rather than total thyroidectomy, unless there are other risk factors such as radiation exposure, cancer syndromes, extrathyroidal extension, or lymph node or lymphovascular invasion. Next slide. And with that, I'd like to thank you for your attendance and remind you of the financial disclosures that I do have for transparency. And I thank you very much for this wonderful presentation this morning.
Thank you so much, Dr. Francis. We have a question from our audience. Dr. Pinner Smith wanted to congratulate you all on the excellent presentation. And she's asking, is the extrathyroidal extension found to drive aggressive disease? Was it found as gross extension or microscopic in pathology? Dr. Banik, I don't know if you want to take that one.
Yeah, I think if I'm understanding the question correctly, you're referring to our finding that T3 disease was associated with multifocality. And so in that case, it would just be pathologic findings of extrathyroidal extension.
Can you hear me okay? Sorry. Yeah, I think Pinner Smith was referring to that. Based on your comment on the T3 tumors being either the 2 to 4 centimeters or extrathyroidal extension. So I do think that, yeah, that answers the question. I wanted to ask you about the poor predictability of preoperative imaging and preoperative studies being able to identify at least bilateral or multifocality. What is the process, or how is it different, the process of consenting a patient for lobectomy versus thyroidectomy in the pediatric versus the adult world? I wanted to see what your thoughts were on that, and any of you could hone in on this question.
I'll make a comment about that. So in children, our approach actually is we do not recommend, if we know they have malignancy going into surgery, we actually just recommend total thyroidectomy up to this point, which is one of the reasons why it intrigued me to start this study. In adults, the review of the imaging is critical. So most radiology, outside community performed radiology, ultrasound reports, they don't mention extrathyroid extension. They don't mention the proximity to the trachea. You know, the isthmus cancers are a little bit different, you know. So once I review the images and there's, you know, some concern, I'm referring more to adult, I will discuss with the patient that there's always a possibility, even though we're going in with the intention of hemithyroidectomy, if I find something that is suspicious intraoperatively, either extrathyroid extension or a lymph node that is concerning, I send it for frozen, it's positive for metastatic PTC, they are always consented for total. And I will typically complete the ipsilateral surgery because I don't want to have to, or anybody else to go back into the ipsilateral compartment later on if they recur there. So you really want to minimize reoperative in the ipsilateral compartment. So if there's any concern or question at all, I will do an elective central neck dissection. And certainly with the T3 tumors, we do an elective central neck node dissection regardless. Because in our hands, and I think this is where Dr. Francis made a comment, that in the hands of people who do these on a regular basis, and they know their own data of complications, we've looked at whether you do central neck dissection versus no central neck dissection, the complication rates are the same, hypoparathyroidism and all that. So knowing that, we go ahead and we have a little lower threshold to do ipsilateral central neck dissection if there's some concern that this may turn out to be, you know, a T3 or potential extra thyroid extension too. So that's how some you know, some of the way I think about making a decision. But as emphasized by Dr. Francis, the ultrasound is really the key. And it's quite variable. You know, once you review the cine, you realize that a lot of the ultrasounds, when they say there's no central neck node, or there's no lymph node metastases, they're looking at a very short segment starting at the hyoid and really doesn't go all the way to where the jugular vein drains into the subclavian, you know, which is where a lot of the lymph nodes tend to metastasize to. So I'll either repeat it in the office myself, or I will, you know, have our center redo it because they have a standard protocol.
Dr. Francis, any thoughts or any comments around this same issue? Do you have the same problems with community-based ultrasounds and the different protocols of ultrasound performance outside of the adult world? I mean, we do see it every day here, and when we see adults, but how is it different? How is experience different in pediatric population?
Well, I think all of us who deal with children have reviewed ultrasonographic reports from outlying institutions that are widely different from what we see when those studies are repeated in-house. There is a paper that was published from Yale University some years ago that found that 40% of thyroid nodules identified in children at outside institutions were not confirmed when those sonographic studies were repeated in-house at Yale. So a lot of sonographers, I think, overinterpret what they see in the pediatric thyroid and believe that they are seeing nodules which cannot be confirmed by other investigators. So I think all of us have been, I think, take with a large grain of salt what we see from outside institutions. The other things that I hope the authors will consider, and I think Dr. Sherman is maybe asking a question about as well, it would be nice to know, I think, what the molecular landscape of these tumors are in this cohort of patients. And are there molecular predictors of bilaterality as well as multifocal disease? So I hope that now that you have this large database of patients, their focality, their clinical outcomes, that your next paper, I hope, will address or be able to address the molecular landscape of those tumors. I think that would be another feature that we could potentially include in future guidelines.
Yeah, thanks, Dr. Francis. Actually, that's quite timely because we are working on a research project right now, more on the translational side, using specimens from this multi-center collaboration, where we are analyzing their molecular profile, as well as their actual immune cell tumor microenvironment profile, and trying to tie those two together to bring some biological understanding to these clinical features that we're finding. So stay tuned.
Excellent. We look forward to that. I think there are 10 things in the chat and 2 questions.
Yep. So we're gonna go ahead and read them. From Dr. Jonathan Wasserman, we have a question. Dr. Banik, notwithstanding the lasso analysis within your cohort, were there children less than 10 years old with bilateral multifocal but without N1 disease or T3? Or the latter 2 factors sufficient to identify the at-risk children?
Yeah, I just was looking through our data to answer that question, and there were very small minority patients under the age of 10 who did not have one of those risk factors. So I think it was about 3 patients out of the 23 that are under the age of 10. We didn't look specifically at whether, and I don't know that we would be able to statistically say anything about whether there's an association there, but it's a small number.
Awesome, thank you. This is a very interesting question from Dr. Sherman. He's asking, are there studies in pediatric PTC to determine if multifocal disease are due to multiple synchronous primary tumors or intrathyroidal metastases from a solitary primary? Go ahead, Grace.
Oh, I was going to say, I don't know if Dr. Francis, maybe you have some more insight into this and want to answer this. Otherwise, I can comment.
Go ahead and make a comment.
Okay, I was just going to say that I think this question reflects, at least to my knowledge, where pediatric thyroid cancer research is a little bit lagging behind the adult side of things, and I don't know of any studies that have looked at that particular question. But I do think it is something that is going to be important to adding to this discussion of multifocality, if it's true multifocality or not.
I'm not aware of any studies that have specifically addressed that question either. I am aware of some data where, for example, BRAF V600E in pediatrics has been identified in metastatic lesions, but not in the primary tumor. But that's a slightly different question.
Correct. Dr. Shindo, do you have any comments on that? All right, so I'm going to jump to a comment from Dr. Int'l. He brings up an interesting discussion where he compares this to the adult world. He says he congratulates you on an incredible presentation, and he says there seems to be an underlying assumption that the presence of even microscopic subclinical disease in the contralateral lobe should be treated upfront as part of the initial treatment. However, we know that in adults that microscopic clinical disease in the thyroid and even in lymph nodes metastases often remain stable for years and slowly grow. And even when they become clinically apparent, salvage therapy works well with no difference in disease-specific survival. So do you worry about making clinicians worry about missing subclinical disease in the contralateral lobe and leading to more aggressive upfront surgery? Or could there be could we be exposing children to lifelong surgical complications, since there are very few high-volume pediatric surgeons around the world? So how do we balance this? I don't know if you want to hone in on this, Dr. Shindo.
How do I know Mike was going to ask that? Good morning, Mike. No, he brings up a very good point. This is, what led to high-level evidence-based decision in adults to be more conservative. And, I think that you're right. But we don't know whether or not the behavior of multifocal disease in children is different than in adults. And I think this is something we will need to look at the molecular landscape before we can answer that. So, similarly, you're absolutely right. You leave microscopic disease in children, certainly 5-10 years later, those who are managing adults, we'll end up seeing some of those patients with disease that becomes clinically evident or progress, that micro disease. So, I think there's a lot more that we need to look at. And I just can't emphasize really the need for multi-institutional collaboration and looking at some of these factors, in particularly pediatric population, to really help determine is this a little different disease than adults? I just don't know the answer to them. You look at sclerosing variant. I mean, that's something we deal with in children a lot more than in adults, for example. So I don't know. I don't know the answer to that, Dr. Tuttle. We had a whole big debate. This is off the side, but now we're looking at radiofrequency ablation, of microcarcinomas, and you have to look at all these different factors. Do we look at the molecular profile of the FNA before we decide that somebody needs to proceed with treatment, and not just active surveillance, for example, for micro disease?
Correct. Dr. Francis, do you have any comment on that? Do you see the pendulum swinging into a less aggressive upfront surgery in the future?
Well, I think the pendulum has been slowly swinging toward less aggressive therapy overall. We're certainly using less radioactive iodine than we used previously. We're allowing young patients to have stable, persistent disease more often than we used to. Back in the day when Mike Tuttle and I were working together, we would treat young patients with radioactive iodine every year with the hopes to eliminate disease. And when we found that disease was stable, we sort of thought we were doing great. Hey, it hasn't progressed, so we should keep treating because we're keeping it under control. When in fact, it's under control whether you keep treating it or not, as far as we can tell from current data. So we've backed way off on that. And I think the pendulum right now is looking at surgery, in particular, upfront surgery. Can we? And I think the data would suggest that perhaps half or maybe even more of pediatric thyroid cancers might be amenable to lobectomy and potentially ipsilateral node dissection. There would probably be an increased risk of recurrence, but so far, our data suggests that recurrence does not impact on overall mortality for pediatric thyroid cancer either. So yes, they may require salvage surgery later on or repeat surgery, but so far, although the data are limited and we need additional studies, as you guys are going to do with this consortium that you put together, so far the data says that recurrence doesn't really impact on overall mortality. So I think we're at a good place to be able to address these questions of more limited surgery. I don't think we have the answer yet, but I think we're at the right place in time to be able to address those questions.
In a similar train of thought from what Dr. Tuttle was asking, Dr. Coben is asking if you are aware of any longitudinal studies that are currently in process or already performed that show data of recurrence in this type of population.
Recurrence data in this type of population. I'm not sure that I understand all the nuance of that question. So, if we say this population is pediatrics, then some of the studies would say recurrence rates on the order of 20 to 30%. If they're asking, is it patients with T3, T4 tumors in 1B disease? I would say almost all of those patients are going to get total thyroidectomy and radioactive iodine. So the recurrence rates are probably lower than that, probably. So I'm not sure that I know how to answer that question.
Yeah, I'm wondering if Dr. Coben was asking in the same regard of having less aggressive upfront surgery, but Again, I'm assuming part of what she wanted to ask you. So thank you for your answer.
I think the long-term follow-up is a little bit challenging unless these pediatric patients are going to be followed by the same center, you know, say Mayo, you know, children, and then at the same center, they're followed as they get older. Because from a practical standpoint, if you look at some of the other places, you know, they transition or they move on, and they, you know, they as they get older, they go to a different place. So that you know, that data may be very difficult to attain.
I agree. Do you, in that regard, Dr. Shindo, do you have any usual precaution or any advice for the physician that is going to follow a patient that is transitioning from the pediatric world to the adult world, and how to follow, or if there should be any difference in how they should be followed in the future?
I think that certainly some kind of communication to you know, the endocrinologist will be monitoring once they become adults, and I think, you know, providing with the most important piece of information, which is obviously not just the follow-up studies, but some of the intraoperative findings that were found, et cetera, et cetera. That communication is probably really the main
Correct. So
thing, and based on that, you would recommend, you know, how frequently, the low risk, the high risk, and how closely you follow these, et cetera.
okay, so we're getting a follow-up question from Dr. Coben saying the question is really whether there are long-term studies following individual patients by risk stratification over time, comparing total thyroidectomy versus lobectomy rather than cross-sectional studies of groups. I don't know if that clarifies the question.
Well,
Go ahead.
at least the studies that I've seen comparing those two outcomes with long-term follow-up are obviously older studies, because in order to get long-term follow-up, you needed to have patients who were operated on in the 1960s and 70s. So yes, the data is out there that total thyroidectomy reduces the risk of recurrence. But I think we all need to keep in mind that those studies were done decades ago. Those procedures were done decades ago.
Correct. Well, we have a comment from Dr. Sherman, and he says, as the father of a papillary thyroid cancer survivor, I would like to comment that the psychological morbidity of a residual or recurrent disease is not trivial. Very interesting and true. Disease-specific survival is not the only endpoint of interest, and evaluating the impact of active surveillance on or minimalist approach. That said, complications from surgery cannot be minimized either as for the long-term impact on the young person, and that's completely true and very, very a thought-provoking comment. Any comments, Dr. Francis, Dr. Shindo?
No, and no, Dr. Sherman, that's a great comment, and I think that, you know, one does have to individualize our treatment. You know, a lot of the patients we treat are teenagers, and, you know, some teenagers can understand the magnitude of, you know, what's going on, and some may not. And you're absolutely right. I think you have to just sort of individualize, you know, the discussion and the treatment. An emotional toll on parents, you know, not just the patient, but the parents.
Yeah, I think another consideration, and I appreciate that, Dr. Sherman, it's a very strong insight into the dynamic of this disease. There's another study that has also shown that patients are more likely to become bankrupt from thyroid cancer than any other form of cancer. So I think that speaks to several things. Number one, the survival overall is much better. But number two, there are going to be so many years of intensive follow-up with expensive procedures. So it's not just the upfront surgery and the upfront radioactive iodine, but it's the long-term follow-up and the potential psychosocial impact of having a chronic disease. So I think you have to weigh the concept that if you did total thyroidectomy followed with radioactive iodine and you reduce the risk of recurrence to as low as possible, and you could potentially back off a little bit on the intensity of long-term follow-up compared to lobectomy, where right now, since we don't have long-term data that's contemporary, those patients are going to have fairly intensive follow-up for decades. So which of those is going to give you a better emotional outcome? I don't think we know at the present time.
Correct. Grace, any thoughts?
No, I think, yeah, thanks, Dr. Sherman, for pointing that out. I think that's something that we see in the pediatric population in general and taking care of children and also their parents, that there are a lot of these kind of underexplored and underappreciated long-term psychosocial, in addition to physical effects that you have to think about when you're dealing with kids.
Correct. So we're very close to hitting the 9 o'clock hour right now, and I want to thank you all for incredible presentations, for very thought-provoking comments, for all the audience for your attendance, for your patience with our technical mishaps. I want to formally apologize to Dr. Francis. I had a little bit of a blackout right here, and you couldn't listen your affiliation. I want to apologize to your entire department, yourself, and TUT.
No need.
Thank you for being here. This is incredible. I'm really happy to celebrate the 2-year anniversary of this webinar series with you here, and we hope to see you back next week.
Thank you so much for the invitation. It was really wonderful to meet, all of you whom I have now met and chat in the chat box with some colleagues that I've known for years. So
I agree. And Dr. Banik, congratulations. We look forward to hearing great things from you in the future.
Oh, thank you so much. Yeah, thanks. This is an honor in many ways. So thanks again.
thanks a lot, everybody.
Bye-bye.